Hello friends, today I'm going to speak on the topic pulpectomy. Matthewson defined it as complete removal of the necrotic pulp from root canals of primary teeth and filling them with an inert resorbable material so that it can maintain the tooth in the dental arch. Finn defines pulpectomy as removal of all pulped tissue from the coronal and radical portions of the tooth. The objectives of pulpectomy involves maintain the tooth free of infection, biochemically cleaning and obturating the root canal space, promote physiological root resorption, and hold the space for erupting permanent tooth. Coming to the types of pulpectomy, there is partial pulpectomy and complete pulpectomy. Partial pulpectomy, one third to one half of the coronal portion of the radical pulp tissue is removed from the canals. Whereas in complete pulpectomy, complete removal of the pulp tissue from the root canal tissue takes place. Coming to the clinical and radiographic indications of pulpectomy, the clinical indications includes the tooth should be statistically important, the tooth previously planned for a pulpotomy that shows uncontrolled pulpal hemorrhage, indicated for any tooth in the absence of the succutaneous teeth. Any deciduous teeth with severe pulpal necrosis, provided there is no radiographic contraindication. Primary teeth with necrotic pulp and minimal root resorption. Primary tooth with an abscess or a sinus opening, and traumatized teeth with fracture or caries involving the pulp irreversibly. So coming to the radiographic indications, adequate periodontal and bony support should be there. Minimal periapical changes associated with sufficient bone support. At least 2/3 of the root length should be available. Internal resorption without any obvious perforation. So the contraindications of pulpectomy, it is divided into clinical and radiographic contraindications. The clinical contraindications include excessive tooth mobility, communication of the roof of the pulp chamber and the region of bifurcation, insufficient tooth structure to allow isolation via rubber dam. So the radiographic contraindications include external root resorption, internal root resorption involving the apical one-third, radicular cyst, dentary cyst, interradicular radiolucy that communicates with the gingival sulcus. So the pulpectomy can be completed in a single visit or in a multiple visit. It can be completed in a single visit for large carious exposure with frank involvement of the radicular pulp and the inflammation that extends beyond the coronal pulp. Multiple visit is indicated in case of abscesses, infections, non-vital primary teeth, teeth with necrotic pulp and periapical involvement. So coming to the single visit pulpectomy, the indication for single visit pulpectomy includes large carious exposure with the frank involvement of the radicular pulp without any periapical changes. Primary teeth with infection or inflammation extending beyond the coronal pulp indicated by hemorrhage from the amputated radicular pulp stems that is dark red and slowly oozing and uncomfortable. Teeth that exhibit clinical syndromes to heat and cold and not to percussion. So the procedure for single step pulpectomy. First, the tooth is isolated and anesthetized. Access cavity preparation is done. Then all the coronal and radicular pulp tissue is removed with broaches, irrigate with saline, and a diagnostic file radiograph or a working length radiograph is taken. The canals should be filled with the aim of enlarging them to permit condensation of the root canal material. Flush out the debris and the dentin shavings with the help of irrigant solution. Then dry the canals with paper points and obturate the tooth completely, sealing the coronal and the radicular pulp. Place the final restoration followed by stainless steel crown piece. So coming to multiple visit pulpectomy. It is studied by Lawrence in the year 1966 and later by Stark in 1973. It is indicated when infection or abscesses or sinuses exist, then non-vital primary tooths and teeth with necrotic pulp and periapical changes. So during the first visit, the access opening is done, tooth is anesthetized and isolated, pulp chamber is deroofed, all accessible coronal and radical pulp tissue is removed with broaches, formocrystal cotton pellet is placed in the chamber and a temporary restoration is done. In the second visit, cleaning and shaping is done, and in the third visit, obturation is done. This procedure involved with cleaning and shaping involved So the second visit is 5 to 7 days apart. Remove the temporary restoration and the cotton pellet. File the canals, progressively increasing the file diameter and complete the biomechanical preparation or cleaning and shaping. You determine the working length, irrigate the canals. An indication of the complete BME is smooth canals that have the same shape as the external walls. Then irrigate and debride. Dry the canals and place temporary restoration after placing a sterile cotton pellet in the chamber. And on the third appointment, obturation is done, which is again 1 week apart. Remove the temporary restoration, irrigate and dry the canals. Start obturating. First coat the walls of the canal with the watery mix of the cement with the help of a reamer, and then use thick mix and fill the canals using lentil spiral. Keep on adding fresh mix till no further cement can be incorporated into the canal. Now seal the pulse chamber with the temporary restoration. Recall after 1 week, and if the patient is asymptomatic, do a final restoration and a stainless steel crown. Now the criteria for ideal pulpectomy obturance include: it should be resorbable, it should have antiseptic property, non-inflammatory and non-irritant to the underlying tissues, radio opacity for visualization in the radiograph, ease of insertion and removal, should not cause any discoloration of the tooth. So the root canal filling materials for primary tooth include calcium hydroxide based filling materials, zinc oxide eugenol based materials, and iodoform based paste are there. The calcium hydroxide based materials include Celopex, Vitapex, and Calcicar. The zinc oxide eugenol is there. Then iodoform based paste, which includes Valkov paste, KRI creep paste, Maisto paste, Vitapex, Metapex, and Endofloss. Now let's see the composition of Valkov paste. It is composed of parachlorophenol, camphor, and menthol. The KRI or the creep paste is composed of iodoform 80%, camphor, parachlorophenol, and menthol. The Maisto paste is composed of zinc oxide, iodoform, thymol, chlorophenol, and camphor. The Vitapex, which is composed of calcium hydroxide, iodoform, and oily additives. So the obturation techniques that are commonly employed include use of a pluggers, amalgam carrier, use of paper points, condensation with moist cotton pellets, injection, lentil spirals, and pressure syringes. Now let's discuss some of the questions that were asked in the previous years. The percentage of glutaraldehyde as a medicament during primary tooth pulpotomy that is commonly used is 2%. Now why 2% is used is because it is only the 2% that has antibacterial properties. Any percentage less than 2% has insufficient antibacterial properties, and concentration more than 2% will be toxic. So the answer for that is option D. Which of the following can be used as a best root and filling material? The answer for that is MTA among zinc oxygenol, amalgam, and calcium hydroxide. Now, why we can use MTA as a root and filling material is because when it comes in contact with moisture, MTA is able to set and harden. None of the other materials have that kind of property. Question number 3. Following amputation of the coronal portion of the pulp of an immature permanent first molar, the stump should be capped with formocrosol, calcium chloride, thymol, and calcium hydroxide. So the pulp capping, the ideal material is calcium hydroxide, MTA, and biodentin. So the option for this is 3D. The ideal root canal filling for primary teeth is which one? Calcium hydroxide iodoform, zinc oxide, gutta-percha, ferric sulfate. The ideal root canal filling material for primary tooth is calcium hydroxide plus iodoform because it has both has antibacterial property, calcium hydroxide and antibiotic, and iodoform has antibacterial properties, and their activity has a synergistic effect. And also iodoform provides the radio opacity that is required to be visible on the radiograph, and both of them are not toxic in any way, and both of them are capable of resorbing on its own. Question number 5. During restoration, mechanical exposure of mesiobuccal pulp bones in the primary first molar with moderate carious lesion on the mesial distal surface, the treatment should be what? So when there's mechanical exposure during restoration, the ideal procedure is to do pulpotomy so that the remaining radicular tissue can remain vital. You do a pulpotomy and you put a stainless steel crown. So the answer for that is 5B. Question number 6. Radiographically, first time chronic pulpal infection of the primary molars noted as. So if there is a chronic pulpal infection, there will be changes in the furcation area. Interradicular radiolucency will be present. So the answer for that is option C, changes in bony furcation area. So when there's a large exposure of pulp within 24 hours, we can go for pulpectomy. But if it is after 24 hours and there is bleeding cannot be controlled and patient comes to within 72 hours, then you have to go for a pulpectomy. So in this case, the patient has come to you within 24 hours and is a large pulp exposure. So the procedure for doing is pulpotomy and option A. The obturation of deciduous tooth can be done with what? We cannot use Gattapacha for obturation of the deciduous tooth because it has no antibacterial properties and it will not resorb. Same goes with silver points and thermoplastic Gattapacha. So we have to use an obturation material that can resorb and has antibacterial property. So the answer for that is iodoform paste. The KRI paste is composed of iodoform, camphor, parachlorophenol and menthol. So the answer for that is option A. In a 3-year-old patient, the cement used after pulpectomy is, we use the most commonly used antibacterial intercanal interim dressing agent is the zinc oxide eugenol. So the option is B and the answer is zinc oxide eugenol. So that concludes my presentation. Thank you.